Good afternoon. It's 1 o'clock and time for the resumption of the Tuesday, June 18th meeting of the Board of County Commissioners. We have a time certain item on the agenda now with Human Resources. It's the medical and pharmacy benefit recommendations for plan year 2019-2020. Looks like we have a good crowd. Thanks everybody for coming. And I will pass the baton over to Ms. Boyle.
Thank you. Suzanne Boyle, Human Resources Director, Indian River County Board of County Commissioners. So at the last meeting, the Commission directed me to hold employee meetings, which we did last week, explaining the recommended plan changes and the introduction of a silver plan and the changes to the existing plan. So what I have before you is the PowerPoint. Sorry that we have to go through another PowerPoint, but I'd like to just kind of review things for people in the audience who may not have had the opportunity to attend one of the meetings. So our health plan costs continue to rise. We have over 3,600 members covered. 48 of those members have had claims totaling $5.2 million. We are currently funding the plan at $18.8 million, which is not sufficient to cover our costs. This plan is a partially self-funded plan. We are self-insured, and we fund it through employer contributions, employee contributions, and retiree contributions. We also purchase stop-loss insurance, which is necessary to protect the plan against high-cost claims that might total over $300,000 in a plan year. Currently, our annual premium for stop-loss insurance is just under $600,000. We are, at the time of this presentation, we were expecting our stop-loss premiums to be around a 20% increase going into the next plan year, but I have some updated information. It's looking more like 28.2%, and the stop-loss carriers are wanting to introduce a laser exclusion, which means they may not cover some of the high-cost claimants. Those claimants would be excluded from stop-loss protection, which is an additional risk to our plan that we didn't know of last week when we were meeting with you. So we ask, okay, what is the county doing in regards to this situation? Well, the county's increasing its financial contribution under this proposal by $2.7 million in the next plan year, which would mean that the county's total contribution would be 80% of total funding. And when I say county, I want to make sure it's the employer's contribution, made up of all the constitutional offices as well. So we're looking at contributing a total of $18 million of the $22.6 million in retired and projected funding to provide these benefits next year. This funding level assumes that 60% of our workforce will remain on the gold plan and that 40% might elect the more affordable silver plan. So why are we proposing two plans? Well, one of the challenges whenever you have to deliver the message that rates are going up and that premiums are increasing are that employees feel that they don't have any choice in the matter. You're taking money out of my take-home pay. I don't have any options. So we wanted to introduce an option that was more affordable but still provided a high level of coverage. And that's the introduction of the Premier Silver Plan, which has an actuarial value of 80%. And I'll explain what that means a little later. Both plans have access to the great Florida Blue Options network. Both plans have access to the same pharmacy network and the same pharmacy coverage with the exception of co-pays. So what's the difference between the silver and the gold plan? The silver plan, on average, will pay out a total of 80% of the average cost of that plan, which means at the end of the year, after all the claims have been paid, the plan will have paid 80% of the covered expenses and the members would be paying 20% through their co-pays, co-insurance deductibles. Under this plan, the deductibles and co-pays, co-insurance, and out-of-pocket maximums are higher. However, this plan is a very competitive plan. It's different for us, but when you look at it in comparison to other plans offered by other employers, it's a solid benefit, a solid plan. The gold plan has a higher level benefit, and that's why it's more expensive. It pays 88% of the average total costs, and on average, members would pay at the end of the plan year, you'll see that the member co-pays and co-insurances and deductibles would have equated out to about 12% of the total costs. It has a lower deductible, lower co-pay, lower co-insurance, and lower out-of-pocket max than the Premier Silver plan. So this is a more expanded comparison of benefits so that members could compare the two benefit offerings. These were handed out at not the first day meetings, we actually handed them out at the second day meetings. We found that getting this into the hands of people kind of helped them look at what these benefit differences were. So we went through what all the differences were between the two plans. You can see that the gold plan is very similar to the plan we have today, with the exception of three things. The ER copay has been increased from $100 to $250. The advanced imaging copay has been increased from $100 to $200. And then the out-of-network coinsurance, it used to be a 40% coinsurance. That has been reduced to a 30% coinsurance. And then the other features of this plan remain the same. Now the question is asked, well, if this plan is somewhat the same as what we have today, but it's got a higher copay for imaging and ER, why is it costing more? It's costing more because our claims experience and the utilization under our plan has gone up substantially. We have some real situations sitting on our plan that will require a high level care and cost associated with that care it's expected to continue. And that's why it is now costs more than what it does today. And interestingly, we look at the silver plan, and the silver plan has some higher deductibles. It's twice as much. Higher out-of-pocket max, twice as much as the gold. Co-insurance of 30% instead of 20%. The inpatient hospital copay is higher. The ER copay is higher, it's $500. By the way, those ER copays are waived if you are admitted to the hospital. So if it's a truly emergent situation which requires a hospital admission, that ER copay will be waived. PCP, which is your primary care office visit, and your urgent care, is $10 more per visit than the gold. It's $35, but it's still pretty affordable. Specialist visit, $60. Advanced imaging, this is a difference. This is a 30% coinsurance. So instead of a copay, it's a coinsurance. And this is the introduction of something that we're calling consumerism. Because under our plan, when we've seen the payment for claims for advanced imaging, say in a hospital setting, that cost is 2.5 times greater than if you go to a standalone imaging facility. So what the plan pays to go there costs more. So what we're trying to do is drive consumerism, where a member actually calls and says, what's my co-insurance gonna be? And shops around a little bit so that they get the most affordable option for themselves as well as the plan. And then under this program, there is a introduction of a prescription deductible. It's $100. Interestingly, we were talking about it earlier, that deductible does not apply to certain medications that are covered at 100% under the Affordable Care Act, such as birth control, statins, some blood pressure medications, some diabetes medications like metformin, and those types of things. So there are prescriptions that are excluded that were covered at 100% under the Affordable Care Act and will still be covered. There's a lower copay for retail generic. It's $5, and that's, again, this is to be an affordable place for people that are seeking generic medications and don't need to buy up to a gold plan. Formulary brands a little more, $50. Non-formulary, $70. Drug copays, all of your copays accumulate to the out-of-pocket max. And your out-of-network coinsurance, rather than being 30%, is 40% under this program. I think I shared with the board last meeting, and I know I discussed it with the employees that we met with, the out-of-pocket maximum, that when you look at the plan difference, that can be a scary number. But I do want to remind the board that 199 out of 3,600 members met the out-of-pocket max under the current plan with a maximum out-of-pocket of $3,000. So the percentage of the membership that actually hits the out-of-pocket max isn't a large percentage when you start looking at 199 people out of 3,600. 3 families met the family out-of-pocket max under our program. The premiums, today employees are paying $50 for single coverage and $267.50 for single coverage. Under the 2 plan offerings, we have the silver plan will roll back premiums a little bit. This is intended for people who are concerned about their take-home pay and are not comfortable with paying additional money to have an insurance program. So this rolls it back a little bit for the employee, but it doesn't roll it back for the employer. The employer is kicking in $50 more a month for single coverage and $200 a month for family coverage. And I'm sure everybody's asking the question, well, why is it more for the silver plan than it is today for the gold? And again, it goes back to the costs and the individuals that are needing care. The cost of delivering that care has gone up for our group. So that requires higher premiums even for the gold plan. And the actuarial difference is only 8% for the benefits that's going to be paid out under the silver as opposed to the gold. Now we drop down to the Premier Gold plan. Again, the premiums that were enjoyed today, $50 for single coverage, $267.50 for family coverage. The employee premium would increase to $110 for single and $400 for family. These are monthly premiums, by the way. And our employer premium is a fixed amount based on what we are contributing, an additional $50 for the silver plan per month and additional $200 for the family plan per month. This is just a little comparison of blue is our current plan, the blue bar. The green bar is what the employer pays, and the purple bar is what employees pay currently out of the total monthly cost of the insurance. You move over one, single coverage for silver. Instead of it being $685 today, which is our current plan, single coverage, it's bumping up to $725. Out of that, the county would pay $685. Members would pay $40 per month. Under the gold, the cost for that coverage is $795 monthly. Employees would pay $110, and the county would still pay $685. Moving over to the current family coverage, currently it's $1,142.50 a month. The county's paying $875 of that, and members are paying $267.50. The silver plan is increasing in premium cost, $1,332.50 a month. Out of that, the county would pay $1,075. Members would pay $257.50. And then over in the gold plan, the total monthly premium would be $1,475. Members would pay $400 of that, and the county would pay the $1,075. This is just a comparison of how our single coverage premiums of both the silver and the gold plan compare to other public employers. Every benefit offering is a little bit different. I'm sure as you saw if you reviewed those plan documents that are for the different employers. But you can tell that our premiums remain competitive, and our Indian River County Gold program is excellent. I call it the sweet plan, and then the silver plan is a really good plan as well. So we've got good and sweet that we can choose between. And then we go over to the employee cost for family coverage and kind of compare how the other employers go. One of the things that's interesting to note about the coverage under either one of these plans is we provide an expanded network of coverage that is quite expensive to maintain for our membership. In other words, we have network coverage out of state. And by purchasing into that network, there's a certain cost inherent in the plan to allow that type of access out of the area. Some programs have limited networks, don't provide the type of coverage that we provide on the various plan offerings to provide out-of-area coverage at the level that we do with the strong network that Florida Blue offers. So it's a competitive and high level of benefit. It is a change. It is a change from where we are today. It's a change in plan offerings. It is an increased cost to the county regardless of which plan the member chooses. And if the member chooses to be in the gold plan, it's an increased cost from where they are today. It's over double for single coverage. It's $60 more a month, and it is $182.50, I think, extra a month for the family coverage. It is important to note that for the past many years, we have enjoyed low premiums. And I want to stress that. We have enjoyed low premiums. Our normal is very atypical for what the cost of insurance is. And I speak with people on a regular basis about what the cost they are experiencing in their both public and private sector experiences. In fact, following some of the meetings, I had an employee who started working with the county within the last year or so, and they were paying for a level of benefit that wasn't quite as good as what she thought our silver plan was, $257 per week for single coverage with a private employer. That was a week. When she COBRA'd, $1,700 a month was her coverage for single coverage. That's the cost it cost her. So ours is still very low and very competitive, although it is an increase from where we are today, and it's a lot more than what our members have been used to paying for insurance and what they've enjoyed for a number of years. The family coverage, $400 for a gold plan, 88% actuarial value. I don't know where else that exists. I haven't quite found it yet, but it could be out there, but ours is a great offering. So let's see. I wanted to also include some information on the employer-employee premium, the history since 2014. And again, our members have enjoyed some really low cost of insurance. So this change is hard. This change is hard for them. No cost for single coverage for 14 and 15. Family coverage was $217.50. At the meetings, I asked folks if they remembered when family coverage used to be $12.50 a month and the hands were raised. And I said, how many of us want that back, right? But there's a lot of things that are happening both locally, statewide, and nationally that are impacting our costs, and unfortunately those days aren't going to come back for any of us. I want my homeowner's insurance prices that were back then too, but I don't have that. So then we moved up to $30 for single coverage in 2016. It went up $20 in 17. Family coverage, $247.50 and $267.50. We were able to maintain those rates for 2 years, and then we have our today. So in our today, the member will choose to go either single or gold, and that choice will result in either a $40 increase from what premiums were back in 2014, or a $110 increase from the free coverage they had in 2014. The employer cost for single coverage will have increased $210 per month regardless of the plan that's selected. And then we drop down to family. Family, the cost for family coverage would have increased either $40 a month if somebody goes silver, or $182.50 if somebody goes gold. And then the county's cost, or the employer's cost, will have increased $360 per month for either plan. Do you have any questions so far about those? Okay. Then we're going to go on into the Clinical Advantage program, the Pharmacy Clinical Advantage program. Pharmacy costs are an area of our insurance that will not be experiencing 8, 9, or 10% cost increases. The trend is looking at 17%, not just for our plan, but that's just a overall in the book of business. Pharmacy costs are going up double digits to 17. I think I shared with you that there is a medication that is filled under our plan that the one medication costs over $600,000 a year for one medication. And in an average 6-month period, we have about 22,000 claims that are being processed through our plan in a 6-month period. So you can see how if you have the introduction of one medication that is a high-cost medication to treat something, it can really have a substantial impact on your plan costs. So we're recommending, we asked for RX Benefits as our pharmacy benefit administrator. They price out our pharmacy benefit contract and look for the best pricing for us. What is our plan paying for those different medications? They run through the claims experience and make a recommendation on who should be our pharmacy benefit manager, who should we contract with at the lowest negotiated rates and the highest rebates to provide our pharmacy benefit. The other thing we ask them to do is look at opportunities of risk. Where are some risk areas that the plan has paying for things that really aren't falling under the medically necessary umbrella? And under that, they've identified that we and recommended that we should exclude low clinical value drugs from our formulary. It's projected to give us about $99,000 in savings moving forward if the plan does not pay for those drugs that have low clinical value. Now, these low clinical value drugs, they are medications oftentimes that are available over the counter, but they have actually been branded with something different, joined two little ingredients joined together that you can get over the counter, and they have a high price tag on them, and they get filled under the plan. So unfortunately, if we don't put any protections in place like this, our plan is susceptible to just having it run through the plan and pay out at a high cost to our members. The other one is the utilization management review. This is a high dollar claims review program that is intended to have somebody look at a claim that is costing more than $1,000 a month and make sure that it meets the requirements of medical necessity. This could involve reaching out to the prescribing doctor for the justification, the medical justification. And through this process, sometimes what happens is by just making that call, the doctor will automatically prescribe a lower cost medication because they know, they're watching. The plan is watching. So if we don't have these types of things in place, we could be at risk of paying out anywhere from $148,000 or $149,000 to over $200,000 in unnecessary expenses under the plan. The other one is a manufacturer assistance program for specialty medications. Specialty medications are very expensive, and specialty medications, they often will offer a coupon to a member to help pay with their copay. You've heard of this, where you don't have to pay anything out of pocket. Here's a manufacturer's coupon. Take your prescription down, because once that claim hits, the plan will pay whatever that cost is, right? And some of it can be really high. But there's money left on the table. The whole value of that manufacturer assistant coupon, RX Benefits is going to go and get that for us and credit it to the plan. So it will reduce our overall expenses. So that's what that program is. And projected savings of $231,000. So that's pretty good for us to do that. And then the final piece of it is out-of-pocket protection, which means that when a member uses a coupon for their out-of-pocket copay, that coupon doesn't count towards their out-of-pocket expenses because they didn't pay anything. Only true out-of-pocket expenses paid by a member will accumulate to out-of-pocket costs, because it needs to be a legitimate, they actually paid this in order for it to total up. And the value of that, it isn't priced out here, but it's the right thing to do so that the members' true out-of-pocket costs were truly what they paid. So this Clinical Advantage program is expected to result in $413,000 in cost avoidance. I say cost avoidance because that's all. Whenever you save $1 here, you're just avoiding a cost. You're just trying to bend the curve down a little bit, keep it not so high as it could be next year. If we have no pharmacy review in place, our plan is at risk for paying for high-cost medications or unnecessary medications that are not consistent with medical necessity and FDA guidelines. So, in summary, the county's increased funding significantly over the last 6 years. Employee contributions have increased as well, yet they do remain competitive. There's an affordable Premier Silver plan that's introduced to provide employees with choice for lower premiums than they're paying today, but I want to be clear, it is a lower benefit. However, the cost of those benefits is consistent with what's necessary to fund into next year, what we need to charge in order to pay the projected expenses out of the plan. We still have the Premier Gold plan. It is a buy-up option. It will cost more than it does today. to have that high level of benefit, but it is an excellent level of benefit. And I had a spouse come up who is in the medical field and share with me, she said, your employees have no idea what they have. The gold plan at today's prices, it's unheard of. It's an excellent plan. Same Florida Blue Options network for both plans, same pharmacy network for both plans, and additional pharmacy reviews to help control pharmacy costs and increase plan costs. Do you have any questions?
Any questions for Ms. Boyle?
Suzanne, earlier you had, I think, somebody from Lofton with you.
Yes.
Are they still here?
Yes.
Is the pharmacy
Yes.
lady here? Okay. So you sent out a list of the low clinical value medications and
Yes.
alternatives.
Yes.
And, that was one of my concerns earlier, that now we're kind of inserting ourselves between the patient and doctor and making a determination. So just looking at this, some of the cardiovascular agents, there's like 4 or 5 of them for name brand for high triglycerides. And the alternative therapy is just a generic over-the-counter omega-3 fatty acids. Do you look at clinically, do they both do the same job, or is there
For the record.
a drop-off in efficiency?
Yes, so my name is Shrina Amin from RX Benefits in Birmingham, Alabama. Yes, so studies have actually shown that for those omega-3 fatty acids, the over-the-counter versions do the exact same thing. So there's no sense in the plan paying a high cost for something that can just be obtained over the counter.
Okay, and so then in all the other categories, there is that level of review that you look at clinical data and studies that show that because most of the recommendations are generic, either a generic RX or a over-the-counter equivalent. So you look at those things from a clinical point of view, and that they have the same performance as the higher priced name brand.
Exactly, so all of the alternatives either work exactly the same way or better than the prescribed medication. So I looked at your plan specifically, and your plan is spending about $30,000 in a medication called Rayos every year. So Rayos is just prednisone. It's formulated in a way that you don't have to take it with food. The AWP for Rayos is about $100 per tablet.
Can you explain what AWP is?
Yes, it's the average wholesale price. So it's what the manufacturer is charging before any discounts or rebates. But the alternative is just regular prednisone, which the member would have to take with some food to avoid any kind of a stomach upset. But the AWP for our alternative, just regular prednisone, is about 73 cents a tablet. So those are the types of medications that are on this list. Either the active ingredient is exactly the same, just small differences like taking it with food, or just something that can be obtained over the counter. There's actually a medication on there called Jublia, which is used for fungal infections, and our alternative studies actually show works better than Jublia. So everything on the alternatives list is either exactly the same or better than the prescribed medication.
Okay, thank you. And then, Suzanne, when you mentioned about the trying to get everybody to be more of a consumer and shop a price for a procedure, I found that very difficult to do, at least on the dental side, and because I knew what the dental code was.
Right.
But if you call up any dentist office and say, hey, with XYZ insurance company, what's your negotiated price for this procedure? They won't just give that to you. They said, no, you got to come in and have a consultation, and they charge you the office visit. And so it seems very hard to be consumer-driven when, and I'm sure it's the same in the medical field, like each doctor probably has a different negotiated contract price with different insurance agencies, and nobody wants that information to get out, because then they'll say, oh, well, you're giving so-and-so more than me, so now, so how do you become a consumer?
Well, I'll tell you what my own personal experience was. My husband had to get an MRI done, and he went to the hospital, not locally here, we actually live in Melbourne, and he called me up and he said, they're telling me my copay is $600 and something, and it was related to a 20% coinsurance amount. And I said, don't pay, no, we're gonna reschedule. And I called the insurance company and I said, this is what my husband's being told. Why is that? And they said, oh, well, it's falling under hospital co-insurance as opposed to the copay. If he goes to a standalone facility, it'll be a lot less expensive to the plan and it will be a lot less expensive to him. And he was able to get it done, $100 copay at a standalone imaging facility. So it really, until you actually hear what your skin is in the game, that's when you start thinking about where else can I get this done. And for example, on the pharmacy side of things, one of the examples I gave is if I went to the silver plan, currently I'm in good health, that might be an option for me because I may want to send my premium over to my medical spending account for my out-of-pocket expenses to help cover any additional expenses. But every year, the kids get back to school, those grandbabies come and love on me, and I end up with that upper respiratory thing, and maybe I have to go down to urgent care on a Saturday. It's gonna cost me $35. They're gonna give me a prescription. I'm gonna go down to the pharmacy. They're gonna run it, and maybe they'll come back and say, oh, that's $98 and change. Well, I'm on the hook for that first 100 because it's a deductible. So the next words out of my mouth might be, is there a generic equivalent? Or I might call some of those pharmacies that I know give free medications, and I might see if this one might be one of those that I can get for free at one of those pharmacies that I know give the free medications. So I'm gonna be a little bit of a consumer just by that experience. It's unfortunate, but when we don't see the increased cost out of our pocket when we go, we don't ask. We don't ask. A $5 copay, a $10 copay, even a $100 copay, and we don't ask. But when it starts getting up there, that's when you start making a few calls. And the other thing is, and Lockton and I have talked about this a lot, is how do we educate our members on consumerism? What are those things that we can do to help let people know that this money that's going in the bucket to pay claims, if we are wise spenders, it's gonna keep us from future cost increases down the road if we spend it wisely today. So those are all things that we're considering as we move forward.
Right, and then, but your one example on the pharmacy thing is, it may be zero to you, but we don't know what the plan cost is, right? So if I go to one grocery store chain with a antibiotic, and I pay a $10 copay, and the plan may pay $50. But I go to another chain, they say it's zero, okay, I paid less, but the plan cost may be $80. So really, if I'm being a good consumer and finding my cheapest price, I'm really hurting the plan more because I don't know what that plan cost is.
Right, and that's one of the things that we're trying to pursue, ways to get good information to people so that they can help preserve the plan assets in that regard. It is a challenge. It's a challenge that we're all facing. Everyone I know who does have insurance, no matter where they work, we're all in it together. We're all experiencing it in the same way. The difference is here at Indian River County, it is just starting to occur in the manner that we've seen it happen for other employers, if that makes sense when I say that.
Okay, I think that's all for now, Mr. Chairman, thank you.
I'd like to follow up on a couple things.
Sure.
So one thing that strikes me is that locally, it could get worse some because we now have the Cleveland Clinic, which is got an expanded doctor network. And an awful lot of doctors that you go to are now part of that hospital. So if I understand what you're saying, the same ears, nose, and throat guy I go to who's a solo practitioner might have a mirror image but tied to the hospital. But if I go to the guy who's tied to the hospital, it's going to end up costing the plan more for the same basic treatment and result.
It's very interesting that you can have varying costs depending on where you get it done.
So it also then layering that in a different way. So I'm sick and I go into urgent care and then urgent care sends me to a specialist. I'm not about to suddenly do research on whether it's in the hospital or not.
No.
So, and generally when I'm sick, I'm less cost conscious. I mean, if I might say I'm damn healthy, that I'm not gonna spend more than $50 for something, when I'm really feeling lousy, I'm getting what's there, basically. So it works against consumerism.
Right.
So the next question, again, it's a tech question, which always sounds funny coming to me, but it seems like for something like this to work big time, there ought to be a members app, because you need something very simple so that I say go to urgent care, get 2 prescriptions. I ought to be able to type in the prescription, prescription drug, and have the cheapest location to pick up that drug from our plan. I ought to be able to, if I'm at home thinking about a doctor call, say what the ailment is or what type of doctor I'm going to, a urologist, an ears, nose, or throat, a heart specialist, and then find out at least if he's or she is tied to the hospital or
Right.
tied to the private sector. So at least that work's done. So I'm just, first off, wondering if that's even coming up in the universe, and how do we get that done? Because that seems to be absolutely necessary. Because I'm really wondering if in a busy world, with all the complexities, consumerism can work without some help from technology.
Consumerism needs help with technology, and the pricing tool that is on the Florida Blue website, they have average cost tools, calculators. What can I expect to pay as an average cost? I do not know if that data is specific to us or if it's just an aggregate of data as a whole.
And if you don't know that, we don't know that.
That's right. That's right. So that's all part of the pursuing the availability of those types of things. And then on the Express Scripts website, they actually have a tool that you can put in the medication in there. And I don't know, are you familiar with that website? Does it price it out, Shrina?
Express Scripts actually has an app that members can download, and it'll tell them the cost of the medication and whether it requires a review or not.
You have to get
Does
an
it
app.
give the out-of-pocket copay or the total cost of the plan?
That I'm not sure, but
Okay.
it does incorporate these low clinical value medications that we talked about. So those low clinical value medications would say excluded on the app.
And direct them to another medication?
Right.
Yeah.
Okay, so that's enough for me there, but I mean, that's something we can't just do immediately, but I think that's something we have to be working for in the reasonably near term.
Yes.
And just to follow up on that point, if I may, Mr. Chairman, like in my example, and I think most people are going to be like this, they're not going to get something based on the cost to the plan. Because I think everybody's going to look at it individually, well, what's it going to cost me? And in my example, I can pay $10 and the plan pays less, but I can go to the other place and zero cost to me, and the plan pays more. And no offense to anybody, but I think everybody's going to say, me first. Why should I pay more just, for the greater good, unless there's some type of rebate program or, okay, you save the plan $20, so you get 50%. No one's going to pay based for the plan first, going to pay based on me first. And that makes it tough to keep the plan cost down.
And if I could add, this is difficult for people to do, to figure out what these prices are. This isn't because we're doing a bad job of getting the information out or other employers are doing. This is by design. I mean, there is a lot of money being made in this country because of this. So we're kind of dealing with the consequences. One of the high dollar claim things I think that I heard about was a diabetes medication. And a patient gets prescribed 1,000 milligram of this diabetes medication, and it was costing over $1,000 a month. They can get the same exact diabetes medication, not a generic equivalent or something like that. Get the same exact one, 2 500 milligram ones. So instead of taking 1,000 milligram one, take 2 500 milligram ones. And I'm not a doctor, but my understanding is that's probably actually better for you because you're not supposed to be going up and down with your blood sugar. And that was costing about $100 a month. So there's nothing magical about that. That is twice as much medicine in a capsule. They're doing it on purpose. Okay, and so there are forces actively working to make sure. So this isn't a fault of the employees for not paying attention. This isn't the fault of the employer for not being able to provide the info. There are people making a lot of money because they're doing this, because they know that people don't know what the impact on the plan is and that it's complicated. So we're trying to change that curve, and others are trying to do it, but there are people making a lot of money keeping us from doing that. So I just want to bring that point up.
And that's a really good point, Jason, because what we're trying to do is initiate change that is in response to the things that we know about. Like under the Clinical Advantage program, these are things we know about. So you would call it the low-hanging fruit, the obvious, that we need to take steps to protect the plan. And there's things that we won't know about until after we go through an experience, and then we learn about it, and then we have to react.
Commissioner Fletcher, do you have something?
Thank you, Mr. Chairman. Thank you, appreciate it. You know, first of all, Jason's point on the prescription level, that's understandable. But I have great difficulty in understanding how a practitioner will prescribe a medication to somebody who's ill, and then we're going to have to deal with it as if it's a cable TV failure, and have to negotiate and then look at alternatives. And who's choosing the alternatives? Who's selecting the other formulary? Who's citing that, all right, we can do this for a lot less if you just go right to aisle 6 and grab that? Or what we can do is we can get a generic form. It may take 2 days, but we'll get that. Oh, are we not weakening our system? I think we're fighting something that's greater than that. It's called rep lunches, and in the doctor's office. That's how we get prescribed. It's very unfortunate, very unfair, and it's a national problem. It's not a local problem. So
Right.
I think we're fighting something that's huge.
Bigger than us.
It's got to be fixed. But all those doctors' offices that are getting $400 and $500 lunches every Thursday and Tuesday, I'm sure I'm offending some doctors in the arena, but I happen to go to a doctor that does not accept those. And that's one step. But more importantly is I don't want to force everyone here to have to start getting to a menu and look into it and then rely upon somebody on the phone as if they're trying to get more reception on their TV when they're ill, to find out what they can do to get better. As you said, you get hit annually. We all get hit annually. School goes back, everybody's getting it. Whatever it is that week, we're getting it. How do you fix it? Then there's a spike. And now we're going to have to negotiate. It's something I just can't accept, except for me, except for them. And I have, as you know, and I'll share it. I mean, I have insurance with the county. I pay for it. And I also have insurance that I almost paid my life for. And it still isn't fixable.
Right.
And, yeah, because I'm out of network, too, on the other. But when you think about it, when you cited the out-of-network, that we have a great benefit, that we have out-of-network and out-of-state benefit, what does that add to this whole process? Because it's a very limited number. It's, again, it's the small amount of individuals that may be traveling and take ill when they're traveling, or retirees that choose to leave us and go to another state. And sometimes they're of the age where they may have other medical benefits afforded to them. So I believe it's a very small number. How much impact is this on the new cost factor?
So it hasn't been broken out, that impact. The impact comes with our claims experience because the networks, the purchasing of the out-of-state networks through Florida Blue can be more expensive than what the negotiated rates are for in the state of Florida. So it's Florida Blue, but when you have Blues nationwide, it's a different level of reimbursement and payment. It's on the same 80-20 or 70-30, but again, that's a percentage of X. And if X varies, then your cost will vary.
I'm blue on blue, and they still won't talk. I mean, it's
Right, because
the
it's
same
an
company.
out-of-state blue. So
Right.
it's not Florida blue,
Right.
it's another state blue.
So let's get back to
Yes.
our employees who have one plan. Where are they when they go to get a prescription that a physician authorized and directed them to have?
Right.
And figured out that chemistry that's going to fix your ailment, and now I have somebody on the phone saying, nah, should you do something else? How much is that to play? Because at that point, you just pick up the good RX card, and sometimes that trumps all the insurance we're paying for.
Sure does.
I
done
cannot
that
believe it.
myself.
And where does that money come from?
Which-
Probably from the rep lunches, the
Oh, I
card.
don't know. Oh, the RX card, I don't know. There's an app,
Nobody knows where that money comes from, but
but I
it
can
just-
get medication, for an uninsured person, you can get medication through that, sometimes less than what somebody's paying through their own insurance. It's strange.
Sometimes zero.
Yeah,
Yeah.
it's
A cardboard with a
the magic card.
number on it.
Yeah.
And then you throw it away, you get a new one. I think what Commissioner O'Brien, didn't we bring something from FAC many years ago about that prescription card? And it kind of, you can actually stack it on top of, and it was even good for your pets. I mean, it was fantastic. And
Yeah.
now they have these cards. Every pharmacy has these cards right in front of their window in case, oh, you don't have insurance, well, grab that. So my point is, we haven't determined what that out-of-network, out-of-state thing is, which could be significant.
The dollar value of that.
We're probably kicking up the ante on our insurance just because you have the right and luxury to do that.
There is a
And most
cost for that.
People travel, they buy travel insurance too. If you have a few extra dollars, you buy travel insurance. And sometimes that'll cover it. There should be riders for that, and I believe there are. Not should, there are riders for that. My point is, I think that we're looking at broad scale, and the masses are going to pay for a few that might need that process, and the same thing with the prescriptions.
And with medical care. That's what our insurance is. It's all of us contributing for when somebody needs it.
And I most certainly don't agree. I would not be on the phone and having the pharmacist on the phone negotiate, although a pharmacist is a doctor. That pharmacist did not prescribe the medication that my doctor, our doctor, feels necessary to bring you back to full health and recovery.
Would you like a little bit of an explanation on how that process works?
Yes.
Okay. Trina, any-
I was trying to draw out.
So through the high dollar claim review, your doctor prescribes the medication. The member takes it to the pharmacy. At that point, there'll be a reject that says there's an extra review that needs to be conducted. The review is conducted by RX Benefits clinical pharmacist. And so we just ask the physician to provide some extra information, like what is this medication being used for? Has the member tried anything else that's cheaper? If there's a cheaper alternative, we'll recommend it to the physician. If the physician strongly feels like that is the only medication that's going to cure that member's ailment, it'll be approved. But you know, there's that extra stop. A lot of times physicians just don't consider the cost, or they know that there's a coupon available.
Lunches.
Exactly. Or, you know, they know that there's a coupon available for a certain medication. So they'll just prescribe the medication just because there's a coupon, so the member might get it for a lower cost, but the plan ends up paying for that. An example of that is Absorica, which is used for acne, right? So there's a cheaper alternative that has the same exact ingredient as Absorica, but the only thing is that the member has to take it twice a day instead of once a day. But there's a coupon out there for the Absorica, so doctors like to prescribe it because it keeps their patients happy. They get it at a low cost, but the plan ends up paying for that cost. Whereas the member can take the lower cost alternative that has the same ingredient. They just have to take it twice a day, and it ends up being cheaper for both the plan and the member.
So how long does this process take? I'm at your window, I'm at the pharmacy as we speak, right now. They say go do a little shopping and come back, or whatever. They'll pick up something, aisle 14. And how long is it gonna be before I can have my medication?
So nowadays, e-prescribing, so I know when I work at a retail pharmacy, most of the medications that are prescribed nowadays just come through electronically to the pharmacy. Doctors don't hand
Right.
prescribe things much anymore. So about 90% of prescriptions are e-prescribed. So a lot of times it's resolved before the member even makes it to the pharmacy. When the pharmacy processes it, they'll go ahead and call the member saying, hey, it does require review. We'll let you know when it's ready. The whole process, depending on the physician and how quickly they get the information back to our reviewers, it can take up to 72 hours.
No, wait a minute. It's Saturday. I was fortunate to get a doctor. I'm sorry. I was fortunate to get a doctor. They write the script, they e-script it, or they hand it to me. I haven't seen a script in a long time either. You're right.
Right?
They e-script it. The pharmacy closes in a couple of hours. I'm waiting till Monday to start getting my medication. That's what it sounds like.
I just want to remind you, these are not going to, these
I
are,
can't even think that this is a possibility.
so this is actually the industry standard. Right now, you're waiting up to 70.
Industry standard, what, we could become a third world nation?
Well, right now, you're actually waiting 72. Right now, you're with Express Scripts doing the review, and anything that needs a review can take 72 hours with Express Scripts right now,
That's not what the doctor said. Doctor said I'm going to prescribe this, start taking it tonight.
right? And these are, I just want to remind you
That's
guys,
what that's
these are
what
medications
we
that
need.
cost over $1,000. So it's not going to be your typical blood pressure medications, your cholesterol medications. These are most specialty medications that treat, things that have to be injected or things that just cost a lot of money.
I'm sorry, I'm not being rough on you.
That's okay.
It
These are valid concerns.
defies sense. Defies sense. Especially when you have children. My children are grown. But you have children and they're sick. You're enduring that. You can't go to work. You can't do anything. You can't mow the lawn. You can't do anything you enjoy if you enjoy mowing the lawn. But you can't. You have to be with that child. And now you're entrapped because we're negotiating a deal. We're trying to see if we can get something on a different market. Oh, I'm going to be back at the ER. And then if I'm not admitted, then that's not waived. So this thing is just going to snowball.
It definitely, under that scenario, it could, but under the implementation of this program, and I've been in discussions with RX Benefits and had that very similar dialogue going on with them. What happens if I have an employee that's gonna go and they have somebody sick and they need the medicine, and they can do a grace fill, so that for that first prescription, or what, something to help so that it isn't that type of an impact. And RX Benefits is actually able to do that, where they make sure that someone can get the medication that they need. And then for prescriptions that are kind of ongoing and going to be an ongoing expense to the plan, that's when that medical authorization, that other level of review can then be implemented before subsequent fills are made. But we do have the ability to do a grace fill and build that into the program parameters.
You didn't mention that. About the,
She didn't know I had that discussion.
you had that little on the side. Okay.
Yeah.
And then, so if that's the case, maybe that'll get us through, and then
Yeah.
they determine they can't. But you said that you're going to yield towards the physician. If the physician insists, then that's the way we'll be going.
So
I think
someone
the other thing,
isn't,
Commissioner, is if you look at the list that they provided here, a lot of these are not your emergency items.
No,
Toenail fungus, so
I guess there's
you
some
come down
therapeutic
with a
items.
cold, you go to the walk-in clinic, they give you a prescription for an antibiotic. I don't think that's gonna get kicked out. You go to the ER because you sprain your ankle or something, and they give you an anti-inflammatory and a pain med. I don't think those are gonna get kicked out. Now, you go to the foot doctor and he gives you a prescription for toenail fungus. I think you can wait 24 hours on that one, so if you look at the list, none of these really seem to be, I gotta have it while I'm waiting here at the pharmacy. And I would think things like antibiotics, pain relief, things like that, would not be kicked out.
And again, for you and I and 90% of the people that are here, and I guess all the people that are here, but all of our employees, but the children, that try to equate that to a child, even though it's lesser of, yeah, I know,
The
but
child
you're
has a
dealing with
cold
the
and
child,
The
it's.
pediatrician prescribes an antibiotic, they're gonna fill it. I mean, upset stomach, might be a, whatever for upset stomachs. I mean, if you look at the list, it really is not those kind of urgent items that's on the list that Suzanne provided, so.
Okay.
As we were looking at what can we do to help keep costs down, there was a lot more that could be recommended that at some point in the future might need to be recommended depending
That's what I'm
upon
saying.
where we go.
Listen.
It does. No, not that regard. I'm talking about narrow networks. I'm talking about maybe not having access to 16,000 pharmacies. I'm talking about directing it to where the plan best deal is. There are some plan designs that are out there that have implemented very strict controls to control costs, to slow the expense, to slow the growth. We don't have that. So I know for us, this is very new and alarming, but when Shrina said this is the industry standard, the recommendation from RX Benefits was, we can't believe you don't have something like this in place already. It's like, if you're having a health plan, you want to have and preserve your assets and not be paying for things that are low clinical value, that don't meet the medical necessity guidelines. So the recommendation is, again, just to preserve the plan, preserve the resources for the benefit of the members, avoid higher rate increases than might be necessary to pay for benefits that don't have controls in place.
And I agree, you mentioned something during the presentation about looking at other jurisdictions and other entities, and even the private sector. Yes, the costs are across the board and higher than here. So we have enjoyed a reasonable expectation. I was one of the $12 folks too. Couldn't believe that. But from it's ratcheted a little bit, but not all that much, but this is a significant ratchet. It basically obliterates cost of living increase and even a little bit more. So basically, everybody gets placed at a zero to have good quality health care.
Yeah.
Thank you.
Mr.
Welcome.
Chairman, just a question for Jason. Earlier this afternoon, or this morning, or whenever, Steve Myers had brought up the concept of a floor and a ceiling in the reserve fund. And I don't necessarily agree with the numbers he put out, but just overall, what are your thoughts on having a floor and ceiling? And that if at some point the reserve account exceeds the ceiling, then that money could be given back to the participating members to help offset some of the cost.
Well, I believe we definitely need a floor. We've got to keep that 3 months in there at a minimum. I think what we can try to do is we can hold off on increases if we have a higher balance, but a lot of the numbers can swing a long ways in a small amount of time. Suzanne talked a little bit about our excess coverage and lasering, and that's not something we've had here, and it's a fairly complex thing, but we've got excess insurance. If somebody has claims over $300,000 a year, we get covered. They cover us for that. But of course, the insurance company's not in the business of losing money. So we have some larger claims right now that a laser means, okay, that $300,000 doesn't apply to that member over there, this, whoever it is, because they know they have an underlying condition. And I can tell you that the numbers we're talking about is like $900,000 this year. And the reason they're wanting to not include that is they're expecting maybe it's gonna be more next year. So if where we're above that 3 month minimum, it can get eaten up rather quickly, and we don't have insurance for that. So that can bring that number down really quickly. So I believe we need to have a higher cushion there than that. 3 months is the bare minimum from the
And I would agree. So let's say we're at 9 and 12 million. Okay, and so 9 million is our floor. We're gonna,
Right.
because of the things you just iterated. So at 12 million, and let's say at the end of a fiscal year, everything's been done, and we're at 13 million. So now we're $1 million over the ceiling. My thought would be, instead of reducing the rate, because then you're gonna start yo-yoing the rate every year, the rate would stay the same, but then we would divide that proportionally among individual and family and give it back as more of a rebate, because that's the excess. So their monthly premium wouldn't change, so we're still trying to keep the plan solvent and not yo-yo the premium. But if we're over the ceiling, we divide that equity, and it's a one-shot, refund kind of thing at the end of the fiscal year if we are over the ceiling. Does that make any sense to you?
My concern with that is you have fluctuations. You have a bad year you have a good year and we rebate the difference to the employees, and then the next year we have a bad year and we don't have a cushion there for that.
I agree,
Yeah.
but we're not changing the rate, okay? Their premium is gonna stay constant. But I think there, if we did something like that, then there'd be more incentive for the employees to find out what the plan cost is, because then they're all working toward trying to get the rebate at the end of the year.
If I may interject?
Mhm.
Given what they say about the increase in medical costs, which continue to go up significantly more than the rate of inflation, if you did it your way, you'd be keeping the reserves low, and while that year would be good, the next year you'd be looking at, say, a 9% increase, and you'd have to raise rates to make up that difference. I'm not sure, maybe it would work better to use that, capture that $1 million.
Yeah, and I wouldn't suggest that we would never change the rate.
No, but if you use the $1 million then, and put that into the fund so that it can be used for any increases while it lasts in the cost, you could either reduce the amount future increases which would be required, or do away with the next year with an increase that might be required. That's,
Okay, and then I would see that, but from the individual point of view, what would you rather have? Money back in your pocket, or, hey, we didn't increase you this
well,
year?
it depends how you look at finances. For me, the money back in my pocket this year isn't gonna make me feel better the next year when I'm paying more money. And it puts people in a harder position, because they're not expecting that, this year I got a rebate, next year I might have to pay it back. And that type of yo-yo thing is I think,
They'd be paying the same thing in both years, because we wouldn't change the rate.
no, but the next year, if medical prices increase significantly, we'd have to the taxpayers would have to pay the full amount, or we'd have to increase the cost of medical insurance to all the members of it. And so that would require an increase. And so one year it could be good and next year bad. And that type of, for financial planning purposes, that type of fluctuation is a killer. And it makes people, I think, it would for me, make me sort of more conservative and more worried about what would happen than less. So I don't know if this is all telling us anything more than this is an awfully complicated subject and we've got a far way to go. But there are so many variables in this.
Along those lines, can you put that slide back up? If it comes, okay. I think somewhat of what you've talked about has actually occurred. The funding of the health trust and the financial recommendation of when do we need to have an increase is based on not only what's the trust doing, but what's the experience doing. And I can tell you that when Budget and Jason look at funding, coming with something like this isn't done lightly. It's done with a financial planning and a wisdom to avoid placing us in a situation that none of us would want to be in next year. So when we look at this history of who's borne the cost and the lion's share of the cost, the county is really stepping up and has stepped up year after year to keep premiums affordable, but also to offer an amazing plan benefit to the members.
I think it's important to realize that nobody here or in Indian River County benefits regardless of which way we go.
Right.
I mean, all the money is going to outside people to pay for healthcare. So this is pain shared among the taxpayers and the employees of Indian River County. And I think what we're all trying to do is to try to reach the best, don't like the word, but sustainable path forward on this, because this item is so crucial and important to everybody here.
Chairman, I have a couple questions for Suzanne. I logged into the Blue Cross site just to check a few things. I tend to try to look for if I need to go to, or my kids need to go to a physician for something, I want to find somebody that's not, their practice hasn't been bought by the hospital. Because we know that if it's, like when they bought the radiology side, that was just a cash cow for them, because now they can do the same work and bill at a much higher rate because it's owned by the hospital. But I thought I was doing a good job, but maybe after looking at a recent choice I made a month or so ago, I thought I purposely avoided picking somebody owned by the hospital, but actually now after looking into it further, you got to go down a couple levels to figure out really who works for who and who owns who, because it's not very clear unless you get down to history and credentials going into the doctor's background. You find out Indian River Health Services. Well, who's that? That's really Cleveland Clinic, I think. To figure out, so maybe I've been 50-50 at best in picking people not owned by the hospital, but maybe I've not been as good as I thought I was trying to do. And if I can't do it, maybe other people have better luck at it, or just know. But I try to stay more to the private practice standalone type of thing versus a practice that's been bought up by the hospital, knowing that the costs are less. But it is a bit tricky to figure out who really owns the practice, or at least it has been for me. Secondly, on what Commissioner O'Brien said on the reserve side, and I think as Susan explained, we've kind of taken the fund balance and absorbed more or less of the premium cost. So we've kind of been doing it, but at some point, if the fund had $25 million in it, we would say that's way too much. At some point, based on the scalable size of your reserve versus your number of employees, your exposure with your retirees, there is probably some magic number, I don't know what it would be, but it would probably be higher than the balance we have today, because you could have, if you had two people had heart transplants or some big ticket item, you can skew the whole pool, even though it's a couple thousand people, those charges could really just change the premium cost for everybody just with two catastrophic events. So
There's a great possibility of large deviation based on our claims experience, yes.
And I'd rather have the money in the bank if they do happen, but at some point when you get up to a number, there probably is a number, and there's probably a good formula to come up with that. I don't know what it would be, but I don't think it's the current fund balance number we have today. It's a healthy number, but if you had two of those type events, you could chop off, a seven-figure number off of that pretty quick.
The other thing to be mindful of is the plan pays unlimited. There's no
Right.
$1 million cap. It is an unlimited benefit per member. So although we reinsure with stop loss, if we have a laser and we have somebody that's excluded and their situation becomes much more serious situation than today, the risk is not capped at $1 million, not capped at $2 million, not capped at $3 million, not capped at $4 million. It's not capped at anything.
When you looked at comparing the other plans, do they also have unlimited
Yes.
forever coverage?
Yes.
They all do, okay.
If
That's-
they're an Affordable Care Act plan.
Right, so it used to be standard to have like $1 million lifetime
Right.
maximum. The Affordable Care Act made that it's not compliant with the Affordable Care Act if you have that maximum.
And this is, we knew when we got out of the old grandfather program we had and went into the Affordable Care Act sort of rules, it was going to have financial consequences.
There are, but what we're experiencing isn't attributable to that. There's a little measure of it that is. The plan was unlimited before we lost grandfather status. It was unlimited at that time. I don't believe we had the $1 million cap in place.
Any other questions,
We'll
Commissioner?
check that.
No, thank you.
Okay.
So let's see if anybody from the public.
We will be.
Might be one or two.
Before I open it up to the audience here.
I do not. I think I've said all that is relevant.
Okay, well, anybody here who wants to speak would be welcome to hear you. You can clearly understand that we probably don't understand this issue much better than any of you here, so any of your questions will be welcome, and I'm sure that as we have the dialogue, we'll all probably learn more from this. Sheriff, good
Morning, Chairman,
afternoon.
Commissioners, Mr. Brown, and Mr. Reingold. Thank you so much for this opportunity, and thank you, Suzanne, for the opportunity as well. We're all working together here. There's no doubt about it. We all realize that there's a crisis. And I want to say just a few things before I sit down and hopefully am allowed to come back. Let's be careful when we talk about health savings accounts, because most of our employees cannot afford that to start with. Let's be careful talking about the insurance cost in different jurisdictions, as well as the private sector, unless we're prepared to talk about the salaries. Friends, the elephant in the room is we have woefully underpaid public servants in Indian River County. Thank you.
Name and address for the record, please.
Good afternoon. My name is Toby Turner. I live at 300 8th Terrace. I'm a retired employee of the Emergency Services District. I spent 36 years with Indian River County Fire Rescue. My question is for Ms. Boyle in reference to the premium. Always asking the employees, trying to get them to do some research for their competitive shopping, or asking for different prescriptions, different formularies or whatever, trying to, put our best foot forward. That's not always possible. It just isn't always to shop around. If you need an MRI, you're going to go to an MRI. If you need a CT scan, you're going to go to a CT scan and do whatever that is. Have we looked into lowering the premiums by asking us once again to take responsibility for ourselves? Is there premium differences in smokers versus non-smokers? Are there premium differences in obese versus non-obese? People who do activities that, I don't know, is there something that can be done as well as from me as a retiree and a family plan, paying $875 more a month now than I do before? So
There are things that a plan can implement. You can implement, like spouses are the most expensive to insure. Some plans choose to have a spousal surcharge. Some plans choose to have a higher smoking rate than a non-smoking rate. Some plans choose to require their membership to complete certain wellness activities in order to avoid even higher deductibles. Some plans choose narrow networks. Some plans choose to limit their coverage. Like say in Brevard County, they have a Health First HMO for an employer up there, which doesn't allow any coverage outside of that network. So there's a lot that can be done. The value of that would have to be costed out based on our demographics to see what that could give you as far as a reduction in premiums. But I would doubt that it would provide what people might be seeking here, which is let us keep the same for what we pay today. I don't think anything is going to deliver that type of a value back to the plan. And you have to, when you're doing things like surcharges and wellness, there's certain guidelines that have to be in place, and you have to administer that type of a benefit. So there's an expense to administering some of the things that you put in place like that.
Okay, so we don't have a different plan to choose from for smoker versus non-smoker.
We do not have, we don't charge our smokers a higher premium than non-smokers. That's correct.
I don't say a higher premium, just I don't smoke, so I need a lower one. That's what I'm asking for. You can charge him whatever you want.
Yeah.
Thank you very much for your time.
You're welcome.
Excellent point.
Name and address for the record.
Age before beauty, I guess. Commissioners, my name is Joe Ehrman, retired emergency service, just like Toby. And I think everybody in this room is definitely smart enough to know what the healthcare cost, what's going on in the world of healthcare. And we know that Washington, D.C. can't get their act together to find to regulate healthcare and do a better job with that. I think that's for sure. But I think everybody in this room is smart enough to know there probably is going to be an increase in healthcare costs, an increase on my part as an employee, an increase on my part as a retiree. But the figures are just extremely high. For a retiree to go from $525 a month that I pay if I want to stay with a gold plan, because if I need to go up almost $4,000 a year, that's way excessive. For a retiree to go to the silver plan, it's, am I correct? It's about $2,500 a year. That's a whole lot, especially I'm fortunate. I have a wife that works, and she's on our plan with the county because her plan with her work is more expensive. But that's a whole lot to ask for retirees. The next question that we have to decide is, are we going to give these employees raises, or are we going to give them a benefit on their health care? Well, part of working for the county, and a lot of people do it, they leave the private sector and come to work for a government job for the use of health care, which is very important, because that's a benefit that they have, because we have been fortunate. I just don't see the need to rush for these big increases that we're talking about at this time if we can do it gradually. I think everybody here is smart enough to know, but I think the sheriff summed it up, is what we need to look at. We're trying to attract people. We're losing people in jobs. I know fire rescue is. The sheriff's department has a hard time retaining people. It's a lot because of the wages. So we need to decide what we're going to do. And to ask, we need to, what Susan said, we need to be good consumers, which we do. And I had an education with Express Scripts that made me a good consumer in healthcare. And I have I like Express Scripts. I like getting it by mail, and I like that. I think that's a great idea. But I'm certainly not going to shop and worry about what, who owns what facility where I'm going to. When I'm sick, I want medical help. I'm not going to take the time to worry about, is it a private, is it a any river Cleveland Clinic issue or something like that? I need help. I need help, and I need to take the time. So I think that what we're asking the employee to do is just really a little bit too pricey right now, and especially on the retiree side. And I'm speaking for myself. $2,500 increase, $4,000 increase in 1 year, that's a heck of a lot. So I think we need to, I don't know if we can ask Susan to go back and sharpen her pencil. I'm sure she's done that. And I know it's a big task, and I certainly wouldn't want to do it, and I commend you for what you've done so far, but I just think it's something we need to seriously take a look at about, what are we doing to the employees and what are we doing to the retirees? So I appreciate your time. I appreciate your effort.
So Joe, I don't think Susan's the right person. I think we need to look towards Jason.
Well,
So I'm going to ask,
he's the man. There's nothing you got. He's the man. That's what he's.
so I'm going to ask Jason something right now.
And I know he can be more creative than we've done so far.
In the last 3 years, Jason, how much has the balance of the fund gone up in the healthcare fund?
It has gone up about $2 million in the last 3 years.
Okay, so I have to actually agree some with Joe. I mean, I think regardless, over a period of time, rates are going to go up for everybody, for taxpayers and employees. They're going to go up. The question is how they go up and how fast they go up. So, and I think that technology may be a solution, but it's not here yet. I think almost technology has to be part of a solution, but it's got to be driven by people like Suzanne, but people like Suzanne in hundreds of different companies who actually get together and press the people in the healthcare industry to do something. But that's still 2, 3, 4 years away. So right now we may have, some people might say we have some excess in the fund. So the question I'd have to ask is, how much of that would be prudent to use to scale up the increase in the healthcare over either a 1, 2, or 3 year period? I mean, I can't do that amount in my head to say how much $1 million or $2 million. This is why I need the spreadsheets, and let Excel do all the calculating for me.
Mr. Chair, with a caveat with that, if you're going that route, That's with everybody knows that if we have 2 or 3 catastrophic events, all bets are off.
We know, that changes all the time. I mean, that's equivalent to the imputed rate of interest in a FRS plan. I mean, if you use 8%, you know, it might look good, but if you drop down to 6%, suddenly you're underwater. So,
Right.
yeah, so I'm going to suggest maybe the $2 million increase, and, but I don't know how much that would reduce the employee's portion to either plan over the time. So let's just say we reduce the silver plan by $10 a month. And how much would be left to reduce the gold plan X amount a month? You know, that type of number. And start with $1 million. I don't know if the board would like to use up the $2 million in 1 year, or say the $2 million for 2 years, and see it. And it would have to be a different figure. It'd have to be like 1 and, so that's.
So I would say, you know, we have looked at a 2-year phase-in for this, which I think with the fairly healthy reserves, we could go along with. I do want to caution, you know, right now, the latest projection we got after March was that we were going to lose about $667,000 this year, but after the December, the first quarter, the estimate was we were going to lose $2.3 million. And my understanding is April was bad, and I haven't seen any May numbers yet. So, you know, we could yet lose that $2 million this year. So I would say because we have maintained healthy reserves, it gives us the ability to kind of do this in a 2-step process. And we've got something we can, do we have something ready to put up on the board? But I do want to caution, this is kind of like, you know, the quarterback steps back and he's gonna throw the pass. He pulls it back. He can't throw the ball where he was going to throw it before. The receiver's done run across the field. So when we get to year 2, that might not be where we're looking at now. It might be in a worse spot. But what we've done is tried to look at how if we could zoom in on that. So, yeah. So if you focus on the left side, this would be the proposed rates for the gold and the silver. So whereas right now the recommendation before you is for the silver plan, we would be at $110 a month for the employee, and for the gold plan we'd be at $110, and for the silver it'd be $40. So we're going down $10. What this does is that does about half of where we need to go on the gold plan. So for the single it would be $85. So we'd be going from 50 to 85, and the plan would be to go to that 110 next year in the second year. But what we have done is we've kept the relationship between gold and silver the same, because the county puts in the same amount whether gold or silver. So we're indifferent to whether somebody's gold or silver. It's going to cost us the same amount. The employee's paying the premium difference between the two is how much more it's estimated to cost. What that does on the family side is, instead of being $400 for the family, for gold, it would be $350. So we're going a little bit over. So instead of $132.50 more a month, it'd be $82.50 more a month. But what that also does is the silver plan becomes $207.50. So now that's a $60 decrease per month from where we are. So since the gold isn't as high, it's still a significant increase, but the silver is actually significantly lower. So instead of being $10 a month lower, like we've proposed, it'd be $35 a month lower for single and $60 a month lower for family. So what I think this does for the silver plan also is, you know, you're going to have those higher copays, or you're going to have something a little bit higher, is you would actually be going on the family plan, you'd be $60 a month less premium than you are today. I would say put that $60, because you're already paying it today, in a flexible spending account, and then when it costs you another $15 for a medication, you pay it out of there. If you want to go the silver. Of course, if you go the gold, it just makes the bite a little bit easier. So basically, that's what the premiums would be compared to where they are. For the gold plan, $85 for single and $350, as opposed to the $110 and $400 as we sit here today. But then the silver also gets less expensive by the same amount. So instead of being $40 a month for the single silver, it's $15 a month. And then for the silver family, instead of the 257.50 we're talking about now, it'd be 207.50. So that would be my recommendation, with the plan to be that we would go to what those proposed premiums are the following year, with the caveat that we may have to adjust. If we have a bad year, it might be more challenging.
So to recap, you're talking about getting to the same rates, but after 2 years as opposed to 1. And as I see it, this gives more incentive for somebody to join the silver plan, perhaps, especially if they're younger and healthier.
It's still, the relationship between the two, silver and gold, is still the same, so it doesn't cost the county more or less, but it does have that dynamic that you've got more money, more in your take-home pay that you can do something with and put it in your flexible spending account. Makes more difference than the $10 a month we were looking at before. So gives somebody more to soften that when they have to pay more for a medication or to go to see a specialist or something.
I don't know how my fellow commissioners feel, but I certainly don't have any objections to the two-step plan for starters, so.
My only concern with that, Mr. Chairman, is staff has given us a price of X that they think is actuarially sound to get us there. And with the two-step thing, first year we're gonna do X minus something. But if we have a bad year, then the second year, it might not just be going to X, but going to X plus something to get back to that actuarially sound number. And that's my concern, because if there's a lot of pushback at X, we'll be sitting here a year from now saying, well, you know what, we got to go to X plus, and where are we going to be then?
Well, my answer to that would be, I think that because of what the reserve has done over the last 3 years, that this would be the time to take that risk. Because even if we used up $2 million of it, the reserves would still be reasonably good and probably be able to absorb 1 bad year. Would be able to absorb 2 bad years? No. But that's going to be catastrophic to everybody regardless. So again, this is basically, we're talking insurance, so this is all about risk anyway. So all I'm saying is that I'm willing to take that risk at this time, but you know, it's clearly not going to be my vote alone that does anything.
And I just, going back to the chart that's in the backup, the last 6 years, including the current year, 4 of the 6 are negative. 1 of them was barely break even. So if we want to calculate the risk, I would say the recent trend is it's more likely than not that we're going to have a negative year.
I wouldn't object to that. Commissioner Zork.
Yes, Jason, on the shift in the fund balance at the end of the year, is part of that is claims, and is also part of it in the last, let's say, 2.5 years, how many new employees have we added, total-wise?
1.
1? No, it's more than 1.
We've added some more
I mean, we've opened up a number of stations. Those are 20-plus people at a clip, so are we 50 people higher than we were?
From the low, we were 720 at the low, and we're up to about 865.
Yeah.
So that's how many, and I think we hit a high of 900 and something, so we're below.
That was like, 09.
Yeah, that was just at the Great Recession. So we've been going up steadily over the last few years, and how many additional hires do you think might be in the budget this year? I mean, they're going to, so they're going to be more this year.
Right, so the question is the reserve going up because we have more younger new employees that maybe are not experiencing a lot of claims, or is it better claim management, or it's probably a combination of, we don't have acupuncture anymore, so that's a big saving. Or we have it, but at a limited plan benefit.
And we have, so our reserve needs to be larger because we've got more employees. We also have more retirees than we did 5 years ago. We've had a lot of people retire in the last 5-10 years, so we're still serving those, and you heard from Toby here, and there are others that are retirees. So we've got a significant number of retirees on the plan as well now. I will say that, and I don't think we have, but it's on the agenda item. If you look at those losses from those prior years, in 2014 we lost about 1.4 million. In 2015 we lost 2.7 million, and we made some significant plan adjustments around then, and then we only lost 1.1 million the next year, and then we got back to a gain the following year. Had we not taken action in 2015, it starts to get catastrophic real quick. You start losing like 4 or 5 million a year, and so that's why we want to do this and be proactive and not get behind the curve, if you will. I do want to say that to raises, I understand this impacts, you get a raise, but then you have to spend it on health insurance. There's something else that's going on out there, and it's not just here, it's across the country, is the recommendation is for the employer to put in $2.7 million more next year. Well, that's $2.7 million more that's not available for raises. So this is something that's been a dynamic going on that a lot of employers, not just us, are constrained with the amount of raise money they can afford because they're spending all this extra money trying to deal with the health insurance increases. So the health it's a double whammy. It lowers the employer's ability to provide raises because the employer's spending a bunch of money on health insurance, and then you start asking the employee for more contribution to the health insurance. So it's kind of a double hit, but it's just a challenging situation overall that everybody's trying to deal with.
Now would probably be a good time to go back to the public who might want to speak. Afternoon, name and address to the record, please.
Good afternoon, Commissioners. Rick Lane, retired from the Indian River County Sheriff's Office. First, I want to plead a little ignorant. I was out of town last week, and Commissioner, I did not see anyone commit suicide on the LIRR. I want to compliment your staff, Suzanne, also Ann Rankin, and for the sheriff, Colleen Boyer. I reached out to them to try and get some more information. So I'm not fully up to speed because I didn't get to attend the workshops that were held last week. Hopefully next year we'll have those spread out a little bit more and give everyone an opportunity to attend those. No one likes paying more and getting less, but let's face it, that's where we're at today. It's where we're going to be at tomorrow. Suzanne, there was a slide you presented earlier showing what the premiums were for last year and what they are proposed for this year. Could we pull
Is it the one that had the multi-years?
I believe it was.
Well, we had this one.
It was the one that had a listing at the bottom of it that said, yep, that's it right there. We'll use that one. So as we can see that our employees, and it's showing $50 for an employee cost for single coverage, but I just want to clarify, down on the bottom it shows employee coverage for single increase $40 per month for silver. That's not actually increased 40, it's decreasing 10, correct?
So actually, I was comparing it since 2014. I wanted to show this is where we were in 2014, this is where we are under the proposal.
Okay, but the actual premium that the employee is responsible for paying for single coverage is going to decrease by $10 per month, correct?
For an employee, yes.
For an employee for single coverage.
Yes.
And for family coverage, it's also going to decrease by 10%, by $10.
By $10, yes.
Okay, for silver, and this is silver, not discussing gold. The unfortunate aspect to that is while it's decreasing $10 a month, for an individual, they're not really going to reap that benefit because they're going to experience the pharmaceutical deductible. And as a matter of fact, when it gets to the point that they're dealing with a family, even if they just simply have 2 people, they're going to be paying out more inclusive of the deductible. The area that I have a concern in is with regards to the retirees. If you'll notice there, and let me just look over here if I could, the retiree insurance for the current year is $875 for the family. That's going to increase $200 per month, which equates to $2,400 a year. That's the additional amount that a retiree is going to be paying for less coverage. And again, I get it, no one wants to pay more for less, but there's an inequity that occurs here. And it's an inequity in relationship to what the applicable cost is for an employee, which is decreasing $10 per month in either situation, and what the applicable cost for the coverage is for a retiree. it's actually increasing. When you calculate the difference there, it comes out to $2,520 more a year that the retirees are having to contribute. Am I correct?
A little bit close.
Okay. I don't have a spreadsheet, so bear with me.
No, I know. I do. All right. So today, our retirees who are on our health plan, some retirees pay the full price and do not have subsidy. If they were hired after a certain date and retired, they pay 100% of either the $875 or the $635 for single or family coverage. But the large majority of our retirees qualify for a subsidy, which means that they pay a reduced rate off the monthly premium. So today, how many years of service did you have?
32.
So you receive a 40% subsidy? Okay, which means he pays 60% of today's monthly cost for his family coverage. So you're paying 60% of $875. Under the new plan year, your cost for the silver plan would increase to a family from $525, which is what you pay today, to $645 a month. So that would be an increase of $120 a month times 12. To go to the gold, which is a buy-up plan, which not a buy-up plan today because we only have the one. And I want everybody to understand the reason we put the silver on the table is because we didn't want the 3,600 people to have to go silver and have to pay that more just to have insurance. So this was the ability to provide something more affordable. But under the gold plan, for you to have family coverage, that's where you would see your big increase, and that's $525 to $885 a month because you are now paying 60% of the full monthly cost of $1,475. So on the silver plan, you're paying 60% of the $1,075. Under the buy-up plan, you're paying 60% of the $1,475. And those are big numbers to have, but we couldn't throw that out there as everybody has to do that. You have no option, and that was the sole reason for introducing the silver, was to provide a more affordable option. For many of our retirees, they're Medicare eligible, and the county's plan is a secondary plan to their Medicare. Well, we've reached out to Florida Blue, and we got pricing on a Medicare Advantage plan that members could actually have, and it would include their spouse who was also Medicare eligible, and each of them could get that coverage for $195 a month, that provides pharmacy, provides medical benefits. It's not a secondary, and that could be a good option for those. But the folks who are retired and waiting for Medicare eligibility, we needed to provide an affordable option to get them from today until Medicare. So this was our best attempt to do that in a very horrible financial situation.
And Commissioners, some of you may recall back in 2003 or 2006 when staff came to you and actually proposed having that additional Medicare Advantage plan.
Right.
We have roughly 18% of the county's 3,600 employees that are retirees.
And on the plan, 340 something, I think is the total.
Okay, so 340. Do you know what percentage of that 340, or the actual number of that 340, are utilizing, excuse me, single coverage or family coverage?
I don't have those numbers in front of me. I know I can get those numbers, but I didn't pull that.
I'm presuming they've been crunched somewhere. My suggestion and request to the board would be that they ask staff to look at that to see if there's some way, what those total numbers would be, and if there is a way to reduce that $2,400 expense that our retirees under family coverage will incur if they stay with the silver plan. Because again, there is a substantial difference there between the actual cost that the current employee is paying for insurance and what the actual cost that the retiree will be paying for insurance. And I know that when we look at statute 1120801, we try to maintain some form of equity there in what we're tasking out to our retirees in comparison to our current employees. So my hope is that when staff crunches their numbers, they may be able to come up with something that's more palatable to the board in addressing the premium for retirees under the gold plan. I get it, I'm sorry, under the silver plan. I get it with the gold plan. As Susan said, we've got good and we've got sweet. I think what we're going to find is a lot of our employees here, and when I say employees, I mean the current paid employees and your retirees, they're not going to opt for the suite because the suite has quite a few expenses in there that's going to make it just not affordable. But I again, want to express my appreciation to your staff for their time in addressing some of my queries. And again, I realize you have a great challenge ahead of you being good stewards of the taxpayers' money. And I still live here and pay taxes, so I appreciate everything that you do. And I know you've got some interesting challenges ahead of you in addressing salaries that need to be addressed and a few other things. But I wish you the best and thank you for your time.
Thank you very much.
Mr. Chairman, between speakers, can I ask Susan kind of a follow-up to that?
Sure, go ahead.
Do both the husband and wife have to be, you said Medicare age eligible for that concept?
For a Medicare Advantage plan,
Right.
they would actually have two different policies under an Advantage plan, and each person would have to be Medicare eligible.
Okay, so if somebody's spouse is 3 years
That's only for
younger,
the
that's
limited,
different.
members of our retiree population who are at Medicare eligible age.
Right, okay. That's what I thought.
Name and address for the record, please.
Ricky Ridge, address Fort Pierce.
Very good.
Retired firefighter. I have a question for you. The gold plan you keep talking about that's a buy-up, isn't that the same thing that I have right now?
It is.
Okay, then it's not a buy-up. Well, it is.
It
It's a
isn't
forced
said.
buy-up.
Yeah.
Okay. I agree with everything that the gentleman before me, said, and with y'all looking to anything you can do to reduce the cost of the retirees. I'm on a fixed income, basically. I mean, yeah, I get a 2.26, which is not as much as what some of the guys that retired before me, and not near what the guys that are going to retire after me. There's guys that are going to not get anything in the future when they retire. They are going to be fixed. What are we doing about them? Are they going to have a $360 a month based on what you sent me? That's what I'm going to have to pay. That's pretty tough. We talked about it. That's a month. That's tough. I might have to go back to work with a bad ticker. I can't do firefighting anymore. I'm looking at bagging groceries just to pay for my insurance. And that's after 25 years of service. I really think y'all need to crunch some more numbers. Please. Do it for us old guys. Thank you.
Thank you.
What's the definition of old? Have you looked under me?
Name and address for the record, please.
I am Steve Carbone, work for utilities. I don't know how the fireman and the police system works, but over our way, we have a called thing 3 and 90. So if you're off, it's called 3 and 90. If you're off for 3 days straight or whatever, you have to bring a doctor's note in. If you're off for 3 days within 3 months, you have to bring a doctor's note in. Now, you got road and bridge, you add the numbers up, I'm not sure what the exact numbers might be, but every time you go to the doctor, say times 4 times a year, one person, and if you're talking 500 people, and the doctor's office costs $400 and $25 for me, what if you eliminated that where we didn't have to do that and you'd save $100,000? Because we're forced to get a doctor's note. Okay?
That's a good point, thank you.
Good point. So you stay home, you're sick, cost you $400.
Hello, Commish. My name is Milo Thornton. I'm a current employee at the Sheriff's Office, and we have about 184 employees that have single coverage, 249 that have family coverage. And I just don't understand how we can ask them to pay more money when we are one of the lowest paid agencies in this area. It just does not make sense to me. So, excuse me. This insurance thing is going to cause a problem when it comes down to retention. I'm just going to tell you up front. A lot of the men and women that sit here, I personally go and tell them how great Indian River County is and how it's a benefit to work here. This is going to cause a problem. When we bring the best and brightest here at fire and EMS and in the other areas that we have, we tell them that Indian River County is all these great things, and it is. We have to find a way, and this is not it. This is not it. Raising the insurance on some of these young single parents that we have employed here that are paying crazy money for childcare while they come out and risk their lives for everybody in this room. But we raise their insurance. There's got to be another way. I don't know where you're going to get the money from. I know it's there somewhere, but it's got to be another way. Because I can't continue to tell them these stories if it's not true. So I'm asking you guys to come together somehow. Let's figure this out and shop it around, do what we have to do. But I'm telling you, there's 184 single coverage, 249 that's got to make a decision. So whatever you can do to help us out, we will greatly appreciate it. Thank you.
Thank you.
Good morning, Amber Greer, Indian River County Sheriff's Office, and I just have one question. You keep saying we have two options. Where's the third option? Where's the option to not select either? For a person that starts off at $24,000 a year, I should not be required to take any. If I want to take my chances and go without and take my money and put it up, that should be afforded to me. Thank you.
Well, Suzanne, they don't have to take the health insurance, do they?
We have people that waive coverage.
All right, so you can do that now. You can waive it.
Not anymore.
AC, Affordable Care Act.
Oh,
If you don't
right.
have it, you get a peanut penalty. Ma'am, name for the record, please.
Kathy Gibson, Indian River County Sheriff's Office. I'm a law enforcement deputy with Indian River County Sheriff's Office and the Secretary Treasurer of Indian River Deputies Association, IUPA Local 6080. In regards to the proposed increase to our health care premiums, I want to say that our agency employees cannot afford to have such an increase. We are currently one of the lowest paid, if not the lowest paid, agency within the area. To compare us to other agencies like St. Lucie and Martin County would be a disservice to our deputies. We are in a recruitment and retention crisis. And to expect us to be competitive when our benefit premiums are potentially going up would only expedite the issue. Also, in regards to the silver plan, that may offer a lower premium, but with a higher deductible. With our current salaries, I'm not sure who can afford to pay the amount in a lump sum, should they have to. So the employees would have to either choose between a higher premium to keep the out-of-pocket expenses lower, or a lower premium due to cost in hopes that they never have to use their insurance, out of fear that they will have to, out of pocket, do a higher deductible, There has been talk about the healthcare being competitive and a great value. However, our salaries are not competitive. Our salaries are not a great value. I feel that any additional premium would cause tremendous hardships to the employees of the Sheriff's Office and probably the employees of this county. That's all. Thank you.
Thank you.
But excuse, who's this guy?
Name for the record, please.
Bruce Anderson, 6379 Cocos Court, Vero Beach, Florida. Pleasure to be here today with all of you, Mr. Chairman, commissioners, staff. Susan, pleasure to meet you, by the way. It's the first time I've had a chance to. I'm a retiree also. You guys will bear with me here just a moment. I've been doing a ton of research over the last couple of days, and if you can indulge me on putting up the program that you had from 2 weeks ago. That's the backup that I originally got.
Is it the initial agenda
Yeah,
item?
the initial agenda item, which would be dated,
June 4th.
yeah, I got May 28th. I don't know if that's the same thing.
Yeah,
It looks like this on the front.
is that it?
Yeah.
Yes.
Very good. I got a few papers here. I guess one of the first questions I wanted to ask is, was there any communication sent out to the retirees or the employees prior to that meeting?
No, there was not.
Okay, and why was that? I'm just curious.
Well,
There-
Bruce,
I mean, as far as the proposed increases and
Bruce, to be
changes.
fair, she's probably going to bring it before the Board of County Commissioners to get their view before she gives it to the employees.
Yes.
I just,
Understand. I mean, that's why a lot of people are feeling kind of blindsided in a little bit, but, again, I echo the same concerns. We know, we're all not, nobody in here is naive enough to think that health insurance premiums are gonna not increase for the future, obviously. At this rate, though, I'd have to say that I was a little surprised myself. 68.5% is the number I came up with for retirees. Now, that's staying in the gold plan, and I fully understand why you call it the gold plan for the cost of how much it is. Let's see. Is the current plan consultant Lockton Companies?
Those are benefits.
Mr. Chair, is it okay to direct questions to staff, or?
why don't you direct them to us?
Got it.
And we're probably going to let Stan.
Just want to make procedure, that's want to make sure I'm doing this correctly for you all. Is the current plan consultant, Lockton Companies, a new consultant for the county? Or have they been here
Second year.
second year?
Yes.
Okay, so that's when you contract them. I had a chance to go out and watch the video from the last meeting. And there were a number of issues that I wasn't even aware of. At one point, there was an issue that came up about the acupuncture snafu or whatever, and you guys have been adding safeguards and stuff to change that. And I think it was, based on the table, I think it was Commissioner O'Brien, I think you were one that made the statement about that's one of the ones we got hosed on pretty bad, I think was the comment you made. I can tell you that, speaking for myself, this is pretty steep. I'm sort of in the same feeling right now with regard to that. I like the choice of word hose because I'm an I'm a retired firefighter, so. Since we're self-insured, I think you guys just answered this, so I want to applaud you, number one, staff and the board, for taking the action that you just talked about as it relates to creating a tier increase over 2 years. Because that's what we need to be doing here right now. We need to start getting creative. And I have a couple of other ideas because I've been doing a number of research based on the comparison municipalities that you all used in your backup here. So that is a doable item. The county could inject funding to help reduce these premiums on the taxpayers. On the employees and the retirees to the plan, or is it just reserves?
The plan is that we will put in $2.7 million more a year as is next year. So we're not just asking for an increase in premiums from the employees. It's a $2.7 million, and I think it was $1.1 million we were thinking, and it depends on the split between silver and gold, but $1.1 million in additional employee premiums, and the employer premiums will be $2.7 million more next year than this year with the proposed plan.
Okay. with that being said, and I'm gonna go to page 2 of this document, where it refers to the second paragraph, where we talk about, let's talk about funding for a moment for this plan. It says that and this is, it's gonna be hard for me not to stay out the employee side of this issue because the lines get a little bit blurred as I move through this, what I'm gonna try to talk to you guys about, and some of the new things that are being done in other municipalities that are on this sheet that you have as comparisons. I have the luxury of actually working with almost all of these agencies, Brevard County, St. Lucie County, Martin, as well, with my position now with the Florida firefighters. So, clarification 1, employer contributions for retirees, because is each figure different as it relates to the percentage of funding? Am I understanding that correctly? Like, because employees should be, higher, the county should be.
Are we speaking of employees or retirees?
Let's go with retirees right now in this question.
So retirees receive a subsidy based on years of service, and that subsidy amount varies from retiree to retiree.
Right, based on years of service.
Yes.
And I don't know if any of you all were up here when that went into place, but that was sometime back in the early 2000s, the supplemental subsidy. And one of the key driving factors was the fact that, I remember talking to Mr. Baird about this, and we had a number of meetings about it where he would go out into the field with the county employees, road and bridge and things like that. And these fine gentlemen and employees would be working here well past, Medicare. And he'd ask them, why haven't retired yet? And he said, I can't afford the insurance. So that's why they stayed. And then, lo and behold, we created this formula to help assist, to help reduce those costs. So just a little history for everyone in the room, how that evolved back in the early 2000s. Employer contributions for retirees were what?
If someone, it's a number, it ranges anywhere from retirees that either pay 40%, 42%, 44%, 46%, so it's a progressive thing, and then the amount varies based on their service. And the lowest subsidy that the county provides is 20% subsidy, and a retiree pays 80% of the monthly premium to continue. So the richest level of benefit is a retiree only pays 40%. The least amount of benefit is a retiree pays 80% of the monthly cost of the premium rate.
Okay. So for example, for me with 20 plus years of service, my stipend or health insurance subsidy from the county is 40%, so I pay the
60%, yes.
Okay, because I was making sure that we were doing this correctly. What about employee contributions?
So employees are a fixed amount. Currently, single coverage is $50 and family coverage is $267.50.
Okay.
And the total cost for single coverage on today's plan is $685 a month, and the family coverage is $1,142.50 a month.
Wow. Okay. And now also there, as part of the funding, when you go back to this sheet, where did it go? Here it is. On the second sheet where it says, currently Indian River County retirees' premiums are calculated based on a reduced monthly premium. In parentheses, it says employer-only portion.
Yes.
Rather than the full monthly premium. And I'm going to just do this now. I'm going to go back to, let's see, 2, 3, 4, 5. If you go back to page 5, which it has this chart, if you want to put this one up, if that's possible.
Wow, that's small.
One more. There you go. Under the gold plan, I was reading here, because this is where the retiree premiums are identified. and it says under the new Premier Gold Plan, retiree premiums will be based on the total monthly premium, which is different.
Yes. So
Why is that?
I'll explain what that is.
Okay.
So in order to, if you look at the silver rate, if you'll go above,
Uh-huh.
okay.
I can tell you for the record, I'm concerned with the gold because that's the
Sure,
plan I have.
I know, but I'm just
Yep,
explaining.
We'll work it, yep.
So the county increased its subsidy when it increased the premium to retirees from $875 to $1,075. But if we used that amount to base your gold subsidy on, you wouldn't be paying the buy-up cost for the gold coverage. So the rate for the gold coverage, it's a true buy-up plan. So instead of having that rate based on just the employer portion, consistent with Florida statute, it's based on the true monthly premium of $1,475. So for your example, today the county's subsidy to you is $350 for your family coverage. Under the silver plan, it increases to $430, and under the gold plan, the subsidy increases to $590. And you have a corresponding increase as well as a retiree. So the county's kicking in a substantial amount of additional subsidy, raising it from $350 to $590 if you choose the gold plan. So there's a lot of money being kicked in there for you. But it does not equate to the same rate as for the lower level plan of the silver plan.
Okay, and I'm glad that the county's taking this step because we're kicking in a bunch here too.
Yes.
For the record from this. So going back to the funding question, I just want to clarify that because that was two different things that I noticed right off the bat when I read the report. The next thing is on the OPEB, which is the other post-employment benefit earnings. Do you all have, I didn't see that report in here with regard to, and the reason why I ask this is because I've talked to a couple of different municipalities and usually, I don't know if this is the case here in Indian River County, but usually it's the largest funding source for the plan, the OPEB earnings. Is that the case here?
It's not the largest source. I can tell you the amount that the OPEB trust contributed to the health plan last year was about $2.1 million. So what happens is there's a calculation that's done. This is required to be done per accounting standards and Florida statute that basically says the retirees paid X in premium. I don't know what the number is, but let's call it $1 million. And we get a report that says we spent $3.1 million on the retirees. So the differential has to come out of the OPEB trust. That's why we have the OPEB charge that we fund the OPEB trust, because it's basically the differential. So whatever the employee premiums are, and I don't know, so I'm just going with $1 million. And in this scenario, it would be $3.1 million would be the cost to cover those retirees. The difference between the $1 million paid in and the cost is what comes from the OPEB trust into the health fund, and there's actuaries that calculate all of these projections and all that stuff, but that's basically how it works.
And just for clarification, because you originally said 2.1 and then you said another million, so it's 3.1, which?
So what I'm saying is the 2.1 million is a real number. I know that's what the OPEB trust put in. I don't have in my head right here what the total retiree premiums are, but it's that calculation of whatever the differential is. I know that the retirees, the premiums they paid were $2.1 million less than the cost to cover the retirees last year, because that's how that number is generated. And I apologize, it may have been $500,000, it may have been $2 million, yeah, so.
And I mean, ultimately, those figures would have to be evaluated to get the right projection for future cost.
Right, yeah, and there's a whole projection of how, yeah.
Okay. Going back to the, so many papers here, y'all, stand by. Oh, and I wanted to point out here on, back on page 2 that I get it, looking at the plan's overall performance, there are some costly issues. under this one particular one, under this bullet where it said top 5 diagnostic conditions by spend are cancer, circulatory, rare conditions, gastrointestinal, and muscular. Is that the order by medical spend? I think, am I using the right term?
Right, those are the categories that the claims fell into, which were the top diagnostic conditions costing the most money. But there's a whole lot of other coverage beyond that.
Okay, but those in the list that they're in is like most expensive to least based on what you have here written, or is it?
It's just the top 5.
Okay, okay. Just for that clarification. So let's go to this page, net revenues. And forgive me, but I think Commissioner Solari said that most of the board up here is about, they're not clear on most of it, as well as probably some of us out here as regard to this process. But what I'm trying to point out to this, or is it up yet? Yeah. We had in 2010, is that number a surplus in that first column? Is that what that represents? The 1.768 million? And then as the claims increased, I just want to make sure I'm understanding this correctly. And then we went all the way to 2.7 million in 15, but then turned around and had a swing of almost 3.5 million all the way back up through 16 and 17. Back up to a surplus of, and this would, considering the fiscal year description, it would be, I guess, the last one prior to what you're proposing, versus 19. On the 2 point, forgive me, I don't have my cheaters on, y'all. 2.358 million on that figure.
Correct. So we had several years of gains, and that you can see that was declining. And then we had 3 years of losses. Then I can tell you in that time period we made some plan adjustments. 2017 was a good year, as it was the 2,385,000 was a gain. 2018 is the last completed fiscal year where I'd call that break even. We had a gain of 144,000, but that's pretty close on about 20 million in expenses, basically slightly above break even there. Yeah.
And I fully understand that this is a moving target for you all. I fully get it. Which leads me to, the next thing. I read all these. I fully understand this. There are substantial increases with the premium silver, like for deductible versus the gold. It's twice as much for family. I'm just using family, for example, through employee. Are these numbers the same, I'm assuming, for retirees?
When you say are these numbers, can you specify what numbers you're speaking?
I'm sorry, at this page now, if you back up one.
Are you speaking of the 2 plan offerings?
Yes.
Yes, the plan offerings are the same.
Okay. Just for my own knowledge. So going to the next page after this one, which is, now I've got them in all different order, so I can't tell you which one's the number of the page, but this is the graph where the comparisons were?
Yes.
And when I went back and reviewed the video from the meeting, I know that Ms. Boyle actually mentioned City of Palm Bay, I think in the presentation, as well as City of Melbourne. I just wanted to point out a couple of things because I just got off the phone literally from the City of Melbourne with a couple of the resources I have there. There is actually another plan. Are you aware of that?
There's 2 plans at Melbourne, an HMO and a point of service plan, and both of them are reflected on this spreadsheet.
Okay. I was told there's a PPO. Are you aware of that?
It's actually called a point of service plan.
Okay.
And it's a POS, and it should be the high one.
Right.
Melbourne point of service, and that provides out-of-state coverage and out-of-network coverage.
Right. Yeah, no pun intended there. that cost for employee, I can tell you, I spoke to a number of people and they did a bunch of research for me over the last 24 hours. There are very few people in that plan.
Just a handful.
I just want to point that out. It's a very, very expensive plan. You'd have to be a chief or, a high administrative paid position because it's very costly. So the majority of them are in the other plan. Moving on to,
On the HMO though, Suzanne, an HMO, it's been a while because HMOs were big in the 90s, I think, and then
Yes.
they kind of went away. Is the way I remember it, if you have an HMO, you have not like a network like we have where you've got people, doctors that are on the program and then you just pay the copays, but you can go see other doctors at a higher cost on our plan. But like an HMO is kind of like, if I need to go see a cardiologist, I have to go to one of the approved.
You have to stay in network on that plan,
Right, and so like if I go to somebody who's not in network.
in the
how
Health
much-
First network.
In the Health First network, how much does the plan pay?
I don't believe there's any coverage out of network
Okay,
because it's an
okay.
HMO. So you
So that
stay
would-
in network for the coverage.
That would be quite a different system from what we have.
Yeah, and I can tell you, the majority of the people on their point of service plan are out-of-area retirees who need some out-of-state coverage. And then I think there were 2 or 3 active employees who had family members in other states that they needed to have coverage for. So they stay on the point of service plan, and then their retirees, interestingly enough, if they continue coverage, they fly down to go to the doctor from where they live.
okay, I understand that. When I was looking at this, I reached out to Martin County as well as St. Lucie County, since you used those in comparisons. And I will echo some of the remarks regarding the differential in total benefit packages, which includes salaries, work week schedules, special operations pay, et cetera, et cetera. If you've looked at these contract comparisons, I know on average we probably get paid, I did, for Indian River County. I don't know where the sheriff's department is on this, but I know we were on average somewhere between 22 to 23% to 28%, depending on the rank in St. Lucie County, paid under, and then Martin was higher substantially. And they also worked the lower work week with 3-week Kelly's a 48-hour work week. So in talking to St. Lucie County, he brought up a couple of things here, which I really believe that along with what you're talking about doing, which is a great idea, by the way, to help reduce the cost in the manner so that way everyone doesn't take a big hit here. Is anyone familiar with the term internal clinical program?
On-site clinic?
Yes. Okay. Does anyone here in Indian River County do that? Because I'm not 100% sure.
I
We
think
do
the
not
school board
currently
does.
offer an on-site.
School board does it? Because I truly believe this is something we really need to research and, get the right people in the room, the shot callers for the labor guys, the sheriff's department. Because I spoke at length to the guys down in St. Lucie, and in fact, they're going so far as to, everybody is shifting to that program because all the medical, the prescriptions and stuff are all free. There are no copays, there are no expenses to the employees. So it's a big savings there, and it reduces major costs because people aren't going all over the place buying it, and I'm saying this because you, along with the gal from Lockton, made some good points about what doctors do, mixing prescriptions and when you go to buy it, they jack the price up. It gets very costly to the plan. And I could see that happen because that's all about business, in this line of work. For those of you that are not familiar with it, what they did was they created a central clinic for all the county employees. Now, this is St. Lucie County with the plans that you have here. And then also, the other one that is in St. Lucie is the fire district has a separate one. It's actually a health trust. But they are all encompassed inside the internal clinic program. So for like wellness visits, things like that. And I heard even now they're going so far as shifting all their cardiac and stuff over to them. So they're having very good success with those costs. So I would put that out there for the board and staff And I can probably help you with some of that information because I work directly, like I said, with these people in a number of the counties here from Okeechobee all the way to Volusia. Yeah, so in using us, the county, our county as an example, you have our county employees, our sheriff's department, and our fire and EMS division, fire rescue division. I don't believe there's any other classes, right?
We have the property appraiser.
Property appraiser.
The court, tax
Okay.
collector,
good.
supervisor of elections.
Well, I'm just saying that, I don't know if you've actually explored it, but there's a lot of good information out there, and in fact, he even gave me the name of the company. Melbourne is actually Advent, because they do the same thing. Melbourne has an interclinical program as well. Martin is actually leaning toward potentially replacing the person they have because of the one thing that they're really after is called a life scan. I don't know if you're familiar with that term, life scan, where they do ultrasound of your carotid arteries and your organs and stuff, and a number of employees. We do it at our state convention in Florida, and there's a number of things that are picked up, you know, where I can tell you that I can probably bring a couple of fire chiefs in here thanking God they went to that event and actually had one of those done because they were, you know, they had some issues and were ended up getting checked and ended up with cancer. So they got it early, and they got it, you know, they're in remission. So that was a big, big deal.
Hey, Bruce, I can just tell you, we offer that now at our health fair, right? I'm signed up for it.
Is it?
And what is it, like $60 or something for the 5?
We also do mobile mammography quarterly on site, no charge.
So we, through our health fair, the employees have the opportunity to do that at a tremendous price. It's $60 for like 5 different tests like that. And I know I'm signed up for it in 2 weeks from now. And as a matter of fact, we had to fill a third day. There's so much demand. We filled 2 full days of appointments and added a third day. So our employees have access to that opportunity.
No, and in fact, I got the information and actually scheduled an appointment myself Thursday. I'll be here Thursday to do that particular thing as well. It's a great plan. With regard to live scan, I think it's a little bit more entailed versus what we're talking about here. I don't believe they do all of the organs in the body and, you know, all of your key arteries in the body, things like that for, you know, potential blockage.
Can I ask you just to focus back a little bit more on the issues before us today there?
Understand. Anyway, I just wanted to put that out there. So a couple of options were mentioned. One, we definitely need all the help we can get from you all on this issue because these increases are staggering, and anything you can do to help them. And number two, I highly recommend and suggest that you all look into what they're doing in St. Lucie and Martin County as it relates to that interclinical program with reduction in costs. So in summary, I'd like to say that you all have a tough job here and you make tough decisions. I fully understand that. You know, all I ask is on behalf of me and the retirees, all the employees out here as well, that you do the right thing for us and help keep these costs affordable, competitive, and sustainable for the future of our employees and retirees. I thank you for your time, for allowing me to speak.
Thank you.
You guys have a great day.
And with that, we'll take a 10-minute break.